Welcome back to Control Alt Lead, the podcast from computing where we talk to IT leaders about what's moving in the market. This week, I'm talking to Perran Pengelly, who's the CTO at DrDoctor. DrDoctor works with the NHS to improve the patient journey. That means cutting down on patient no-shows, surfacing important information for doctors pre-appointment, and providing some of the core technology behind the NHS app. We talk about a huge variety of the issues facing healthcare today. So that could be the new look hybrid approach to healthcare, the NHS's long-standing issues with data centralization, the use of AI in health, including both its opportunities and its challenges, and also, quite importantly, as DrDoctor is a private supplier to the NHS, the controversy around the NHS's use of private partners. It is a great interview. Please enjoy. Perran, thank you for joining me today. You've come from DrDoctor, so I think the best place to start is a brief introduction to the company and what your role is there.
Okay, thanks, Tom. It's good to be on here. So DrDoctor, we are a company working with the NHS, and we're trying to help them move to what we call hybrid healthcare. And what we mean by that is there's a problem at the moment that the demand for healthcare, the amount we need it, far outstrips the capacity that we have to supply it. And we can't fix that problem by building enough hospitals or training enough staff, because it would take too long and it would be too expensive. So we're trying to look at how can we do as much as we can outside the walls of your healthcare provider. And then it means healthcare teams can monitor people remotely, see who needs to come in, see who's responding well to treatment or not. And then when you do need to come in, we facilitate that and make it as easy as possible, and try to get everyone prepared so that your interaction with your doctor or nurse is as valuable as it can be. So hopefully gone will be the days where you have repeat 3-month follow-ups, where you take a day off work, you travel in, you come in to see your doctor, they say, "How are you doing?" And you say, "I'm fine." And they say, "Great, see you again in 3 months," because that's not actually valuable to anyone.
No, absolutely. And as DrDoctor's CTO, what does your sort of day-to-day look like?
Yeah, so DrDoctor, CTO for me is both product and tech. So it all comes under one house. So it's everything from making sure that the product works well for users, it's having the right impact, they're enjoying using it, through to scanning what's coming down the track technology-wise and in the industry, what competitors are doing, through to the technical side of how are we building and delivering this, how do we integrate with all the old systems, how do we make sure there's no downtime, and the system's resilient.
Great. You're experimenting quite heavily with AI in healthcare. This is one of the ways that we can free up doctors' time, is or widely accepted of being one of those ways. It's got great potential, but I'd like to ask you, as an IT leader, how do leaders like CTOs and CIOs prioritize the areas to invest in?
Yeah, it's a great question because there's a lot of potential for it, and it's talked a lot at the moment. The way we're looking at it is for all the different applications of it, trying to understand what the impact would be for that and what the risk is. And you've certainly got to start with what the problem is you're trying to solve. If you start with the technology and the tool and try and find the problem, it won't be very useful. So the types of problems and domains, there's different ways to split it. I like to think of, in terms of the risk and the impact, is it back office or front office as a first bit? And then within there, what is it you're actually trying to do? So is it a productivity gain, or is it something trying to improve someone's actual health outcomes? And each of those will have different risk levels. So for instance, back office productivity, it could be around the comms that a patient's doing. There's an awful lot of phone calls, emails, letters, that kind of thing going between patients and healthcare teams. And productivity for doctors could be around ordering tests and freeing up their time so they can spend more time patient facing. And then the actual improving health outcomes. There's some companies looking at predicting diagnoses or that kind of thing, which is very exciting, but has a very different type of risk level to it.
Absolutely. So, talking about risk, AI in healthcare is an inherently risky proposition. So, what are some of the important safeguards to consider when you're looking at implementing AI in a healthcare setting?
Yeah, and when we talk about AI as well, it might be worth separating out. I guess you could call it traditional AI, which seems a funny thing
Yeah,
to
no
say.
one's really settled on a nice a word for it. Analytical AI, traditional AI.
Analytical AI, yeah, I like that.
Yeah.
That compared to generative, and we've got some analytical AI models, and they're a bit more straightforward because a bit more predictable, and so you can build test cases around those. We look for model drift. You've got automated suites that run. If we ever make any changes, it will compare one model to the other model before anything gets pushed into production. So that's a bit more bounded, and some companies have got medical device certification for those things. So there's a bit of a path there already. Generative AI is a lot newer, and it's definitely evolving at the moment. And there's some good practices emerging around that. There's a new acronym I've recently heard, which is Gen AI Ops, which is the process of all your sort of build, test, and release around generative AI models. And they've got some good tools now. Some will be out the box, so it will check it for quality and risk and safety and bias, and that it can't be jailbroken or that kind of thing. There's a bunch which comes out of the box, which is good, and then you can supplement that with prompts that you give it as well and check its outputs. So a combination of the pre-built stuff and then your extras on top. And again, you need to be doing this before it goes live, and then for the models which are live in production, keeping an eye on them.
Yeah. You talking about Gen AI Ops gave me a flashback to about 5 years ago where everything was ops. We had AI Ops and DevOps and DevSecOps. Oh my God, there were so many. So people on video will have seen me roll my eyes when you said that. Okay, so that is fascinating. I hadn't heard of Gen AI Ops before, but it does make sense as an area. Um, on the NHS side of things now, you work very heavily with the NHS, of course, and a lot of what you're doing is bring data together. So I'd like to ask you, why is data sharing and also data standardization across the NHS such a sticking point? We've seen so many attempts at centralizing all that data with care.data and the federal data program and that kind of thing. So yeah, I'd be really interested in hearing your perspective on that as an insider.
Yeah, the data and integration with systems is one of the hardest bits of what we do. That combined with process change, interestingly, for people in hospitals, because software doesn't do much on its own. But on the data side, so we've got about 70 different NHS organisations we work with, and about 40% of the hospital appointments come through our platform. So we've got reasonable experience of trying to stitch these things together. And there are some standards in healthcare. There's things like HL7 and FHIR, which give you a starting point for how to exchange information between systems. The trouble with these things is these standards are implemented differently by different systems. And then even for a particular system, it will be used differently in different places, like operationally. So if you're looking for a particular data field, one team might in the front end record it in this part of the system, and another team, even in the same hospital, might record it in a separate place. And so there is a big process that we go through trying to consolidate all this information into something standardized and structured for us. And the NHS app we work very closely with. When you're using the NHS app, you'll actually be using our systems in the background a lot of the time. And the reason for that is it'd be incredibly difficult for the NHS app team to scale up to be able to do all of these integrations with all the different hospital systems everywhere. So they use us for that.
Well, that's great to hear. The NHS app, which a lot of us a lot of us now rely on, is built on a nice modern system with data standardization.
Yeah, it's a great system. I think makes absolutely perfect sense for the patient, because you want one place to go to as your front door. You don't want to have to log into lots of different systems, and you don't want to have to care about what's happening in the background. So yeah, we're very supportive of that.
Absolutely. Yeah, the NHS, of course, has been built from the ground up with the trust model, um, which I think if it were being built today would look very different. But unfortunately, just doing a rip and replace is not quite so easy on something the size of the NHS.
No, it's huge, and you've got to think about all the actual on the ground processes that are built into all these different teams. I think, like you said, if you started with a standard blueprint and built it up from scratch, you could do that. But to try and impose that on teams everywhere wouldn't really work at this point.
Yeah, which is why big programs like DrDoctor have failed in the past, of course.
Yes, yeah. The NHS doesn't have a great history of the big centralized IT programs. Uh,
Mm.
I think, although we're talking about standards being different in different places, I think it has to be the way to go. And there are things like the UK has its own FHIR profile now, which is for that standard how we say it should be used in this country. So the more suppliers can align on that, the easier it will be to do this.
Great. Okay. My last question for you is, you are obviously a private partner of the NHS, and there has been some controversy over the NHS's use of private companies. I'm specifically thinking of one whose name starts with P and rhymes with Allantir. I really am interested in your take on that. You mentioned right at the top of our talk here that it would be impossible to scale to the level that the NHS needs by just building more hospitals and recruiting more staff. Is that part of it? Are we just basically buying in expertise?
So uh, my first split for understanding the private companies' involvement is, are those private companies doing the caregiving, which is where I think the NHS is excellent at and will continue to be, or is it around support services? And I think it's unreasonable to think that the NHS, on top of all the caregiving activities, could also create its entire supply chain across all the different areas that it needs. So at some point, it will have to use private companies. And that could even be down to who prints the letters and posts them. It's not always the big exciting bits. With the data things in particular, I think that NHS is in a unique position to have an incredibly large and diverse data set, which it could use to its advantage. It can get the help of private companies to leverage that to end up giving better care for patients in the end. And we're going to have to do something differently, because the costs of healthcare are continuing to rise, and it's not sustainable without it.
Brilliant. Perran, thank you so much for joining me today.
Thanks, Tom.
Thanks for listening to this episode of Control Alt Lead. Next time, I'll be sitting down physically, for those who watch video, with Javed Iqbal, who is the Digital and Information Director at British American Tobacco. We're going to be talking all about how tech is helping the company move toward a smokeless stance. As always, head over to computing.co.uk for more IT leader interviews, research, and analysis. See you soon.